Hello, my name is Scott Haas. I am the Chief Medical Officer for Bluegrass Regional Mental Health and Mental Retardation Board and the Chief of Staff at Eastern State Hospital in Lexington, Kentucky. Today we're going to be talking about psychopharmacology. Psychopharmacology is the study of medications used to treat psychiatric disorders, and so today we're going to talk about a number of different items including neurotransmitters, medications, their side effects, in order to provide an overview of those medications and processes involved in psychiatric illness and their treatment. This is not meant to be an in-depth presentation on the subject of psychopharmacology, but it should provide a good thumbnail sketch of what you would need to know and be aware of while dealing with patients who may or may not be prescribed psychiatric medications. The overview will cover neurotransmitters and mental illness, antipsychotic drugs, antidepressant drugs, mood-stabilizing medications, sedatives and hypnotics, beta blockers, narcotics and analgesics, and a brief summary of psychostimulants. When we talk about neurotransmitters and mental illness, we're talking about dozens and dozens of substances that are known or suspected to act as neurotransmitters and impact mental health. Some of these are acetylcholine, catecholamines, serotonin, also known as 5-hydroxytryptophan, gamma-aminobutyric acid, also referred to as GABA, glutamate, and endorphins. Acetylcholine is involved in rapid eye movement sleep, one of the sleep cycles that we go through every evening, and it helps regulate the sleep-wake cycle and has strong involvement in memory processes in the brain. Degeneration of cholinergic cells is believed to underlie memory deficits associated with Alzheimer's disease, and we'll talk a little bit more about acetylcholine's relationship to Parkinsonism and Parkinson's disease a little bit later. Catecholamines are a broad group of neurotransmitters, and they include norepinephrine, epinephrine, and dopamine. They are involved in functions relating to personality, mood expression, memory, and sleep. In particular, low levels of norepinephrine and dopamine are associated with some forms of depression. High levels of dopamine are linked to schizophrenia, Tourette syndrome, and aggression. Serotonin, or 5-hydroxytryptophan, is another neurotransmitter that is associated with schizophrenia and autism, particularly when it is found in excessive levels in the brain. Low levels of serotonin have been associated with depression, suicide, PTSD, obsessive-compulsive disorder, and aggression. One of the strongest correlations between serotonin and suicide was published in a study in which those individuals who had committed suicide by very violent means, such as using a gun or jumping in front of traffic, were associated with extraordinarily low levels of serotonin. Gamma-aminobutyric acid, or GABA, is linked to sleep, eating, seizures, and anxiety disorders. Decreased levels contribute to the motor symptoms found in Huntington's disease, and gamma-aminobutyric acid is found, like many neurotransmitters, throughout the brain. It has a number of different functions and exerts its effects on a number of different areas and processes in the brain. But what's important to remember about GABA is that, on the whole, it always acts as an inhibitor of processes. GABA tends to slow things down in the brain. Glutamate, unlike GABA, is an excitatory catecholamine, and it's also found throughout the brain and exerts its effects on numerous parts of the brain and numerous processes as well. However, glutamate tends to increase activities of neurons or pathways throughout the brain. Therefore, where GABA is considered more like a brake pedal for the brain, glutamate would be considered the gas pedal for the brain. It plays a role in learning, long-term memory, and high levels of glutamate lead to seizures, Huntington's disease, and Alzheimer's disease. Endorphins are associated with pain-killing properties of the brain, control of emotions, memory, learning, and sexual behavior. As I stated earlier, when we talk about psychopharmacology in general, we're talking about psychoactive drugs or psychotropic drugs, which are those agents that interact with the central nervous system in a way that produces change in either mood, consciousness, perception, or behavior. Psychotropic drugs either increase or decrease neurotransmission at the nerve synapse. Antipsychotic drugs are also known as major tranquilizers and neuroleptics. And the reason they have historically been referred to as major tranquilizers is because this group of drugs have a strong sedative side effect when they are administered. More recent developments have produced antipsychotic drugs that do not have such sedative properties, but the first drugs that were developed were quite sedating, and thus they were given the name major tranquilizers. It's not a term that is used much any longer. Our goal in psychiatric therapy is not to tranquilize our patients, but to improve their functioning. When we talk about antipsychotic drugs, we're talking about two types. The traditional, which I mentioned just a moment ago, that were also referred to as major tranquilizers. These are also called conventional antipsychotics or first-generation antipsychotics. The second group are called atypical antipsychotic drugs. They're also referred to as novel or second-generation antipsychotics. The traditional or first-generation antipsychotic drugs are primarily used to alleviate psychotic symptoms and treat schizophrenia, acute mania, delusions, and hallucinations associated with major depressive disorder, as well as other forms of organic psychotic disorders. They act primarily by blocking dopamine receptors in the brain to reduce dopamine activity. As we'll talk about a little bit later, it is this blockade of dopamine activity in the brain that leads to some of the unwanted side effects and long-term complications of this class of drug. Side effects include dry mouth, blurred vision, tachycardia or increased heart rate, urinary retention, constipation, sexual dysfunction, and tardive dyskinesia, which is an involuntary rhythmic movement of different parts of the bodies. Frequently it affects the jaw, lips, tongue, and extremities. Another side effect that I've not listed here, but is very important to be aware of, is called akathisia. It's spelled A-K-A-T-H-E-S-I-A, akathisia. And akathisia is a sensation of internal restlessness that is experienced by a patient taking these drugs. When this side effect is experienced by a patient, people will notice that the patient seems fidgety, agitated, cannot stop moving. They may pace often. They may not be able to be comfortable in any position. When seated, they will feel like they need to stand. When standing, they may feel like they need to sit. When lying, they may feel like they need to get up. The bottom line of akathisia is that these people cannot get comfortable and they have this internal sense of discomfort and restlessness that is pervasive throughout the day. Oftentimes, clinicians will misattribute the symptoms of akathisia to agitation caused by psychosis itself, and thus try and treat the agitation or psychosis with increasing the amount of drug. As you might expect, increasing the amount of drug will only lead to increasing the feelings of internal restlessness and agitation. So there are other ways that this side effect should be treated when it is noticed. But it is something to be aware of and to keep in mind when you see a patient taking antipsychotics who may be experiencing restlessness and agitation. The atypical antipsychotic drugs are also used to treat schizophrenia, some forms of bipolar disorder, and alcohol and drug addictions. Their mode of action is to also block dopamine receptors in the brain, thus reducing dopamine activity in several parts of the brain. Side effects of the atypical antipsychotics include dry mouth, blurred vision, tachycardia, urinary retention, constipation, sedation, and tardive dyskinesia, as well as the potential for akathisia that I mentioned a few moments ago. The important thing to know about the atypical antipsychotics is that they do not tend to cause any of these side effects with the frequency that first-generation or traditional antipsychotics do. One other long-term complication of treatment with atypical antipsychotic drugs is not mentioned here, but is called metabolic syndrome. And metabolic syndrome is one in which the individual tends to gain weight, have increased lipids, increased cholesterol, and increased blood sugar levels. Antidepressant drugs can be broken down into three primary classes of drugs. The first is tricyclics. The second is selective serotonin reuptake inhibitors, or SSRIs. And the third is monoamine oxidase inhibitors, or MAOIs. Tricyclic antidepressants are used to treat depression that primarily involves decreased appetite, weight loss, early morning awakening, other sleep disturbances such as difficulty falling or maintaining sleep, psychomotor retardation, and anhedonia. Anhedonia is a loss of interest or desire for any activities that would normally seem pleasurable to the person. The tricyclic antidepressant's mode of action is to increase the levels of norepinephrine, serotonin, and dopamine in numerous parts of the brain. Now, as you can tell, tricyclics hit a number of neurotransmitters, and that leads to the perception of tricyclics as what we would call a quote-unquote dirty drug, meaning it is not pure or selective like some of the other medications that we're going to talk about. In being a dirty drug, it hits a number of different neurotransmitters and creates subsequently a number of side effects, including cardiovascular symptoms such as heart block, increased heart rate, dry mouth, blurred vision, urinary retention, constipation, sexual dysfunction, confusion, drowsiness, fatigue, weight gain, and even a fine tremor of the extremities. Selective serotonin reuptake inhibitors, or SSRIs, are, as the name suggests, rather selective, making them a quite clean drug to use to treat depression. They are used to treat depression, particularly melancholic depression, obsessive-compulsive disorder, bulimia, panic disorder, and post-traumatic stress disorder. Their mode of action is to increase the level of serotonin by blocking its reuptake in the synapse. I'm not sure how much you've had in terms of neurobiology or neurochemistry, but the synapse is where two nerve cells come together in the brain, and they communicate with one another by transmitting neurotransmitters across a small gap in between the cell known as the synapse. Serotonin reuptake inhibitors act by blocking the cell's ability to recover or capture the serotonin that it has put into the synapse. The nerve cell releases serotonin into the synapse, which allows for communication with the cell adjacent to it, and then immediately starts trying to recover the serotonin so it can recycle it and use it again. SSRIs block that uptake process, thus leaving more serotonin in the synapse, allowing for a greater effect on the nerve cell adjacent to the one that released the serotonin. In that way, they're able to increase the activity that serotonin can exert in different parts of the brain. Side effects include gastrointestinal disturbances, insomnia, anxiety, headache, dizziness, anorexia, tremor, frequent urination, and sexual dysfunction. As you can see, the list of side effects for all these medications is quite long, but these are the most common side effects that are seen when we utilize these medications. It should be noted that SSRIs, on the whole, as a group, tend to create fewer side effects and less severe side effects than the tricyclic antidepressants that we discussed a few moments ago. Monoamine oxidase inhibitors, or MAOIs, are used to treat atypical depression. Atypical depression is different than traditional concepts of major depression in that atypical depression includes anxiety and what we call reverse vegetative symptoms. When I spoke earlier about the tricyclic antidepressants and their treatment of major depression, we mentioned a few of these vegetative symptoms: sleep disturbance, loss of appetite, and those vegetative symptoms are seen in a reverse scenario with atypical depression. Individuals that have atypical depression tend to sleep more, much more, than someone who is not depressed or someone with major depression. They also tend to overeat instead of suffering from a loss of appetite. Patients suffering from atypical depression are also extraordinarily sensitive to interpersonal insults. Any kind of criticism will be perceived as a great insult from someone suffering from atypical depression and may create a significant emotional response. The mode of action of monoamine oxidase inhibitors is to deactivate the specific enzyme, monoamine oxidase, that breaks down various catecholamines in the brain: dopamine, norepinephrine, and serotonin. Much like the SSRIs, it results in an increased level of these neurotransmitters in the synapse in various parts of the brain, thus increasing their availability and their activity. Side effects include dry mouth, blurred vision, tachycardia, urinary retention, constipation, sexual dysfunction, insomnia, agitation, confusion, skin rash, weight gain, edema, headache, dizziness, and tremor. These drugs are also known to cause orthostatic hypotension, which is a condition whereby a person suffers from a sudden drop in blood pressure upon changing from a seated or lying position to a standing position. The most problematic part of using monoamine oxidase inhibitors is that there are a number of diet restrictions that must be rigidly adhered to if a patient is going to take one of these medications. If they do not follow the diet closely, then diet restrictive items being combined with a monoamine oxidase inhibitor can result in extreme episodes of hypertension or dramatic rises in blood pressure that can be very dangerous. Mood stabilizing drugs include two primary types of medications: lithium preparations and anti-epileptics, medications that are primarily used to treat seizure disorders. Those would include carbamazepine and valproic acid. There are others that are anti-epileptics that are used by psychiatrists sometimes frequently, but many of those are not FDA indicated or proven in the literature to actually benefit patients with any statistical significant difference over placebo. Lithium is the drug of choice for treating bipolar disorder. It reduces and eliminates manic symptoms and suppresses mood swings, helping to keep a patient stabilized within a defined range of mood expression that is not considered to either be depressive or manic. The effects of lithium on mood and how it works are not well understood, despite its being around for nearly 60 years, but it does appear to be related to dopamine, norepinephrine, and stabilization of nerve cell membranes. The side effects of lithium are apparent usually fairly early on in treatment, but do typically subside within about 2 weeks. They include nausea, a fine tremor of the hands, polyuria or increased urination, and polydipsia or increased water intake. Toxicity from lithium shows many of the same symptoms that the early side effect profile shows, which can make it confusing to discern which is a side effect and which is due to toxicity. But toxic symptoms include nausea, vomiting, diarrhea, asthenia, ataxia, confusion, lethargy, polyuria, seizures, and coma. The important thing to note is if you suspect a patient being toxic, it should be reported to their clinician, and a simple blood test can be ordered to determine the level of lithium in the blood, and corrections can be undertaken if necessary. Lithium is also known to be toxic to both the thyroid gland and kidneys, and patients who have taken lithium for many years, especially at high doses, may show abnormalities in their lab workup related to kidney and thyroid function. Carbamazepine and valproic acid are two of the anti-epileptic medications that are used as mood stabilizers. They also treat bipolar disorders, especially when lithium is not effective. Carbamazepine in particular is effective for people with frequent mood swings, a class of bipolar patients that we call rapid cycling bipolar disorder. And those individuals fluctuate rapidly compared to the normal course of bipolar disorder between manic and depressive episodes, often going from one to the other within a matter of a few weeks and experiencing this many times in a year. The mode of action of carbamazepine and valproic acid are not well understood, but are believed to be related to membrane stabilization as well as an effect on GABA receptors. Side effects of carbamazepine include dizziness, ataxia, visual disturbances, anorexia, nausea, rash, and cardiovascular symptoms. One severe complication of carbamazepine is a reaction called Stevens-Johnson syndrome, where the patient will develop a painful sloughing off of the skin on the palms of their hands and the soles of their feet. So if you ever notice what looks like a very ugly rash and skin coming off of the hands or the bottom of the feet on a patient taking carbamazepine, you should alert their clinician as soon as possible. Side effects of valproic acid include sedation, gastrointestinal disturbances, liver injury, and pancreatic necrosis. Sedative hypnotics are used for a number of reasons in psychiatry. In low doses, they reduce general arousal and motor activity. In moderate doses, they induce sedation and sleep. High doses can be used to put someone to sleep for surgical anesthesia, for example, but may also, in an uncontrolled setting, result in coma and death. These are addictive medications, with the exception of azapirone, but the barbiturates and the benzodiazepines are both addictive medications, and their sudden discontinuance can result in withdrawal symptoms that can be quite significant. Barbiturates are a class of sedative hypnotics that are rarely prescribed anymore in psychiatry. They have strong sedative and anesthetic agents. They are still used for surgical procedures and to control some seizure disorders, but again, they are rarely used for direct psychiatric purposes. Their mode of action involves interrupting impulses. I'm going to start that one over, Calvin. Barbiturates are a class of sedative hypnotic medications that are rarely prescribed for psychiatric indications any longer. They are used frequently in surgical procedures, and neurology will use them to treat seizure disorders, but their utility as a psychiatric agent has waned over the years. Their mode of action is to interrupt impulses to the reticular activating system in the brainstem, and side effects include slurred speech, dizziness, irritability, and impaired motor and cognitive performance. Benzodiazepines are used to treat anxiety and sleep disturbances, seizures, and are also found to be useful in controlling symptoms of cerebral palsy. Benzodiazepines are quite frequently described for Calvin, I'm going to start this one over too. Benzodiazepines are a group of sedative hypnotics that are used to treat anxiety and sleep disturbances, seizures, and are also found to be useful in cerebral palsy. They are prescribed with great regularity in psychiatry and have utility across a number of psychiatric illnesses. Their mode of action is generally to increase the efficiency of GABA binding to its receptors. Therefore, as we talked earlier, having an inhibitory or slowing effect on the brain and certain brain processes. Side effects include drowsiness, lethargy, slurred speech, ataxia, and impaired psychomotor stability. Now, as I mentioned at the beginning of this section, benzodiazepines, along with barbiturates, are highly addictive medications. They produce both a physiologic and psychologic dependence. But it's the physiological or physical dependence that they create that will cause the most problems from a medical perspective. When patients abruptly discontinue or dramatically decrease the dose of benzodiazepines or barbiturates compared to what they had been taking, particularly if they had been taking the dose for a long period of time, you will see a withdrawal phenomena that is quite dramatic and will show hypertension, elevated body temperature, tremors, sweating, and even psychosis. If left untreated, benzodiazepine and barbiturate withdrawal can result in seizures, coma, and death. It is considered a medical emergency, and if it is recognized, it must be referred to a clinician so that treatment can be directed at the withdrawal immediately. Azapirone is a medication that is used to reduce anxiety symptoms without causing sedation. Unlike the barbiturates or the benzodiazepines, azapirone is not addictive. It is not habit-forming, psychologically or physiologically, and is not subject to abuse. The downside to azapirone is that unlike the barbiturates and benzodiazepines, it must be taken for several weeks before its clinical effect is recognized. Beta blockers are not considered psychiatric medications by design, but they have been found to have great utility in a number of areas of psychiatry. They reduce palpitations of the heart. They help reduce the tremor that can be caused as a side effect by several medications, including antipsychotics, lithium. They help control excessive sweating, which is useful for patients that suffer from various types of phobia or anxiety disorders. And they also help with other physical symptoms that are associated with anxiety. Their mode of action is to decrease the activity of epinephrine and norepinephrine. And they don't only do this in the brain, but they do this in the periphery as well. Therefore, beta blockers can have physiologic effects on numerous organ systems throughout the body. And that's what leads to some of their problematic side effects, which include bradycardia, or slowing of the heart rate. That slowing of the heart rate can be significant if the dose of a beta blocker is too high. Shortness of breath, arterial insufficiency, nausea, depression, and dizziness. These medications, much like barbiturates and benzodiazepines, should not be discontinued abruptly, because you can have what is called a rebound phenomenon, where someone may have been taking a beta blocker for many years at a moderate to high dose. Their body has adjusted to the effects of slow heart rate. If you abruptly discontinue the medication, it could result in a dramatic increase in heart rate that could create medical complications requiring emergent treatment. So again, patients on beta blockers should never discontinue those abruptly or without talking with their physician. Narcotics and analgesics, primarily we're talking about the opioid class of drugs. They have both sedative and analgesic properties. They're used for a number of reasons, including providing a short-lived rush or sense of euphoria. They are then followed by a feeling of tranquility, drowsiness, apathy, decreased physical activity, and impaired attention and memory. One question that I often receive is, why would we have a drug that we give to a patient to create a sense of euphoria, in effect getting a patient high for a clinical purpose? And I think one of the best examples is what happens with military personnel when they're severely injured on the battlefield. There is no other way to address the pain and shock of a severe traumatic injury other than to use an opioid medication that does create this sense of euphoria and decreased pain sensation. The mode of action of opioids is to reduce pain perception, especially emotional responsivity to pain. Now, what that means is that oftentimes the pain or the painful stimuli is still present, and the body may still be responding to the presence of pain with increased heart rate or increased blood pressure. But opioids have a way of making the brain and consciousness not overly concerned with the fact that the pain is present. So it's not necessarily that opioids eliminate the pain. They eliminate a person's care about that pain. But they are very useful. All of the opioids are very useful in controlling pain conditions. Side effects include constricted pupils, decreased visual acuity, increased perspiration, constipation, nausea, vomiting, and respiratory depression. Overdose or toxicity can lead to slow and shallow breathing, muscle rigidity, catalepsy, clammy skin, decreased blood pressure and pulse rate, convulsions, coma, and death. One important point about opioids is the issue of tolerance. Tolerance is the body's way of adjusting to a medication that has been put into its system and sort of overriding the effect that that drug may produce. So for an opioid, that feeling of euphoria that is experienced, the body tolerates and adjusts to that rather quickly. Therefore, in the future, it will create a need for a higher dose of opioid in order to create the same effect. Now, the body responds and tolerates to the sense of euphoria, but the body does not tolerate and respond to the side effects and the physical complications of opioids. So people that continue taking increasing doses of opioids put themselves at great risk of accidental overdose by slowing their breathing, decreasing their blood pressure, and heart rate. Withdrawal from opioids is also problematic. Opioids, like barbiturates and benzodiazepines, are highly addictive, both physiologically and psychologically, and abrupt discontinuation or dramatic decrease in their dose will result in a withdrawal process. Unlike barbiturates and benzodiazepines, however, opioids do not have a fatal withdrawal scenario. The withdrawal course, however, is quite uncomfortable for a patient and includes pretty much the reverse of all of the side effects that you see. So for example, someone withdrawing from opioids will show dilated pupils, no sweating. In fact, in late stages of opioid withdrawal, they will show goose pimple flesh. Instead of having constipation, the person withdrawing from opioids will have pretty significant diarrhea and an increased heart rate. Here are some of those signs and symptoms broken down between early symptoms of withdrawal and late symptoms of withdrawal. Early symptoms of withdrawal, again, would include agitation, anxiety, muscle aches, increased tearing, runny nose, sweating, and yawning. Late symptoms of withdrawal would include abdominal cramping, diarrhea, dilated pupils, goosebumps, nausea, and vomiting. Increased blood pressure is another common problem seen with opiate withdrawal and should be managed with appropriate medication. So again, if you see a patient who has been taking opioids or you suspect has been taking opioids and is showing any of these symptoms, referral to their physician is in order. Psychostimulants are a class of medications that are used to increase activity and functions in the brain. There are two main types, the amphetamines and methylphenidate. Amphetamines are used to treat narcolepsy and attention deficit hyperactivity disorder. Methylphenidate, also called Ritalin, is used to treat attention deficit hyperactivity disorder in both adults and children, narcolepsy, and a condition called postural orthostatic tachycardia syndrome. That condition isn't real significant for you to know, but for those that are curious, again, postural refers to when you go from a lying or seated position to a standing position. People who suffer from this syndrome when going from a lying to a standing position have a sudden drop in blood pressure and a dramatic rise in their heart rate. Methylphenidate can be used to successfully treat that condition. The mode of action of both psychostimulants are to increase levels of dopamine and norepinephrine in the brain. The side effects for amphetamines will include restlessness, insomnia, poor appetite, tremor, palpitations, and cardiac arrhythmias, and symptoms similar to paranoid schizophrenia after prolonged use, especially of high doses. The side effects of methylphenidate include anxiety, irritability, depression, euphoria, sadness, nausea, abdominal pain, decreased appetite, and may also cause slowing or stunting of growth in youth. Anticholinergics are a class of medications that oppose the activity of the neurotransmitter acetylcholine. Now, the anticholinergic medications that we're talking about here, benztropine and trihexyphenidyl, are not generally used for their direct psychiatric benefits. They don't really produce psychiatric benefits, nor are they used to treat any particular psychiatric illness. But they are used to alleviate neuromuscular side effects that are caused by antipsychotic medications. And these side effects may include Parkinsonism, tardive dyskinesia, and muscle rigidity. Now, I use the word Parkinsonism and not Parkinson's disease because Parkinson's disease is a disease process affecting a specific part of the brain that results in a degeneration of a certain type of cell that produces dopamine and results in the symptoms that we see in Parkinson's disease. Parkinsonism, on the other hand, is a process, not a disease, but a process whereby the balance of acetylcholine and dopamine has been disrupted, such that symptoms that are shown in Parkinson's disease are exhibited by the patient. These symptoms can be precipitated by the use of antipsychotic medications. Benztropine and trihexyphenidyl successfully treat Parkinsonism. To some extent are helpful in the treatment of tardive dyskinesia and can also be very helpful treating muscle rigidity if that rigidity is caused by an antipsychotic medication. Their mode of action is to block acetylcholine receptors in various parts of the brain. helping to restore the balance of acetylcholine and dopamine in various control centers of movement and coordination. Side effects include dizziness, dry mouth, urinary retention, constipation, blurred vision, you will see pupillary dilation, tachycardia, and decreased sweating. Overdoses do occur with anticholinergic medications, both accidentally and sometimes created by a physician who may be prescribing a higher than needed dose, and it can result in a unique delirium. The delirium is much like any other delirium in terms of how the person may be behaving, but what you will see that is unusual are some physical characteristics that are particular to anticholinergic toxicity, and that is their cheeks and skin will become red, flushed, their pupils will be quite dilated, their skin will be very dry, and they will be delirious. So the saying, red as a beet, dry as a bone, and mad as a hatter has been attributed to anticholinergic toxicity. That covers the overview that we wanted to present today, and I hope that you have found it useful. Again, this was just a thumbnail sketch of the different types of drug classes that are used in the treatment of psychiatric disorders and some of the medications that may be used to treat side effects. This covers the most common medications that you will see, their primary uses, modes of action, side effects, and complications. But for those of you that may wish for more in-depth information or may just be looking for a guidebook or handbook that you could carry with you for reference in the future as you're doing your clinical work, these are two that I would recommend. They're both in my library, and I find them very useful for students, interns, residents, clinicians, nurses, just about anyone working in the clinical field where psychiatric medications could be involved. The first is the Handbook of Psychiatric Drugs by Lawrence Albers et al., and the other is Delmar's Mini Guide to Psychiatric Drugs. Again, my name was Scott Haas. It was my pleasure to be speaking to you today, and I hope that you have found this useful.